Well, thanks very much. That was incredibly helpful, and each of the three presenters did a great job of putting everything in the context of the Supreme Court ruling as well, particularly Lucinda, where she was when it happened. And I want to ask everybody, if you didn't recognize these cards that were in the middle of your table, they're for you. Don't have your name on them, but just take one. And start writing your questions of the panel, because I'm going to take just a couple of minutes to ask a couple follow-up questions, and then we'd like to get your questions up here between now and 7 o'clock, because you people are all the ones that are going to have to work on the answers and have to know exactly what's happening. I'll just make one additional observation of the one I made earlier about the presentation, and it sort of relates to how lucky we are to be Minnesotans, and maybe a lot of us spend a lot of time talking or complaining in our lives about that sign out there that says, you know, I'm not a health policy expert, I'm a doctor. I saw that immediately when I walked in, and I don't know any doctors in Minnesota except the very young ones, I guess, that haven't become health policy experts over the last umpteen years. But I also remember that, you know, the people that I admire the most and the people that I just wrote a little piece about Dr. Baumgartner, who was my doctor, because I read something that said the solo practitioner is about to be extinct, you know, and it's a recruiting firm, recruiting physicians, that said that it's just a matter of time, that 75% of the new hires are all into hospitals or hospital-related systems. So I started writing this little piece about Dr. Baumgartner, who came to the house from Albany, 8 miles up the road from Collegeville, always carried his black bag and his stethoscope, and I guess my parents felt better. I didn't feel necessarily better, but right away, but my parents always felt much better after Dr. Baumgartner left. And I reflect on, there are too many to mention, but I always think of Bob Kelly up in Grand Rapids and Jim Knapp in Detroit Lakes. And I can go around Minnesota and I can name doctors who were my mentors in one way or another. And so I'm sympathetic, as everyone here I'm sure is sympathetic, with the role that care providers, particularly physicians, have been playing. And I can say to you that this is, for a variety of reasons, this is a time which had to come. Nobody knew exactly when it was going to come or how it was going to come, and nobody certainly anticipated the horrible politics of it. But I can say, as somebody who's been at this for a whale of a long time, this is a time that had to come. We couldn't keep going in the other direction with some combination of bad policy, and some of which I was involved in, reduced payments for whatever you did, and alternating from one Congress to the next what the instructions are that you have to meet for the next Medicare payment thing that we come up with. So we had to sort of like put it all together, and that's what the Affordable Care Act basically has done. And it isn't a matter of something being invented in Washington. None of that was invented in Washington, D.C. It was invented in communities like our own. And it was learned by Democrats and Republicans over a long period of time, in which I served and after I served. And Democrats and Republicans, particularly in the Senate Finance Committee where I served, put it all together somewhere between the MMA in 2003 and December of 2008, when the Finance Committee published a 95-page document that had a lot of the outline of what you see now in the Affordable Care Act. And tonight we've had, in the 45-minute presentation, the excellent, you know, when you translate all that policy into specifics, is where the rubber meets the road. When you talk about disparities, and I think about them as the social determinants of health, it's the simple things like a job, housing, and things like that are big factors in doing what Ed said we need to do. And when you think about the Medicaid program, you know, this started out as a county program. It's probably going to end up as a county program. In other words, it's all coming back home. It didn't get invented in Washington, D.C. It got invented at the county level. They went to Washington and asked for money, and that's how it all transpired. And insurance, has been a casualty product for a long time, as we know. And health insurance now is different. And it's different because a lot of people who went into the health insurance business, including at least one of your former employers, has changed the definition. So that in effect, over time, it has the information with which to partner with the provider community, whether it's hospital, doctors, whatever it is, to change the system. On the way, I would argue, to extinction. Because if everything goes the way it's likely to go, a lot of these, if we continue to see everybody's being employed, the idea that we're going to have all these insurance companies out there dictating the future, quite unlikely. The future will be in the doctor's office. I have a 32-year-old doctor. How did a 78-year-old body end up with a 32-year-old doctor? Because I've discovered that the people in their 30s are sort of like Dr. Baumgartner was. They got the same set of values. They work longer hours than some of these people do. But they got the same set of values that Dr. Baumgartner had. And so do their husbands in many cases. Which says something. And we attribute it to lifestyle or something else like that. But this is a time that had to come. And when you put all of that together across the generations and across all these so-called health businesses, it's really quite interesting. So as you are preparing your questions now, and I have just 1 minute left, 2 minutes left to ask my question. One of the questions I wanted to ask, whichever, maybe it's Lucinda, but we didn't talk about long-term care. And I wonder if, as you look at the ACA and put all of this in context, and you put in context the fact that the Medicaid program is the fallback, and yet it's now the big payer for long-term care. As we talk about all of these populations that are being served, and now we're going to add 14, 15, 16 million more across the country. We lost the Class Act, and we lost any reasonable approach to long-term care. What is there in the ACA that gives us some hope about the future of using Medicaid and in long-term care?
Well, Senator, I think that was, while there's much good in the Affordable Care Act, I think the fact that it didn't really tackle long-term care reform was a major, was one of the major challenges. And to lose the Class Act was at least like a long-term care insurance starter program, I think was really unfortunate, which to me is one of those things why we have to look at that here in the state of Minnesota. It's one of the reasons, like we're launching this September as Own Your Own Future campaign to encourage people to save for long-term care, but also look at how we can, in the long term, look at having more incentives in our Medicaid program to encourage people to save for long-term care. I mean, there are a few things that help with long-term care in there. I think the whole idea of moving to is this me?
Sure.
Thank you. I think one of the potentials for the accountable care organizations, and I think you're right, we're ultimately going to be driving to where it's providers who are more in the driver's seat instead of health plans and making decisions, which I, from my perspective, think is a good thing. But ultimately, if we have those accountable care organizations, not just on the kind of more acute care side, but we actually also integrate, as Dr. Ehlinger was saying, social services and the long-term care in our behavioral health system. So we're not just shifting people from silo to silo anymore. That, I think, is a real opportunity for us and something we've got to look at here in Minnesota. But overall, I think my response is, that's something they have left to the states.
Yep. Manny, I've got a question for you. People who earn up to 400% of the federal poverty level, which is $44,680 for single people, are eligible to apply for tax credits to offset cost of insurance, which you pointed out, if you purchase it in the exchange. The Congressional Budget Office estimated that about 18 million eligibles will be applying at an average of $4,780 per member per year, or whatever it is. And it'll cost the Treasury $681 billion between 2014 and 2021, which of course scares Republicans. So they oppose the notion that the IRS has surfaced in a ruling they made in May. A rule that the credit should apply regardless of whether insurance is purchased in a government exchange or not. Are you aware of the ruling, and do you have a view on, because not everybody's going to have an exchange. You said we're going to have one here, but I'm curious to know if you know what the realities are about that.
Thanks, Senator. I'm aware of the ruling. I also am aware of a paper that just came out articulating the argument that for the lack of a phrase in the ACA, the federal exchange can't actually issue federal subsidies or the tax credit. I will take the same tack that I did when asked about, are you planning and preparing for the Supreme Court decision? I will say this, and our team will say this, until someone tells us to stop doing what we're doing, we have a lot to do. And we don't spend a lot of time speculating about what may occur until it occurs, because the reality of what we have to accomplish. And I will phrase it this way: we're trying to build an IT solution for 1.2 million Minnesotans in a little bit over a year. That's enough to keep me up at night. So when I have time, I can engage in that conversation and go, thank God somebody else has to worry about that. So.
Okay. Can I get to the questions? Just give me a couple of them, Janet, and I'll get started. I've got a whole bunch of them here, but I don't want to ask my questions, so. These? Okay. Gee, this is of Dr. Ehlinger. Name describe some of the valuable community preventive services that save lives and decrease costs. How, and in parentheses, how can primary care doctors best be involved and contribute?
Well, there's a good example that we've had in the state, and that is smoke-free bar and restaurants. Freedom to Breathe Act certainly is a community preventive service, and the experience down in Olmsted County that has been demonstrated, the heart attacks that have been prevented and the costs that have been saved, is a good example of a kind of a community preventive service. And the Freedom to Breathe Act would not have passed as quickly as it did without the involvement of organized medicine and physicians throughout the state. You guys took a leadership role, organized medicine took a leadership role in that, and really the power of the docs throughout the state really helped move that along, certainly with a lot of other partners. But that certainly is one of those areas where we really, medicine had a huge impact on a community preventive service that's benefiting everybody in the state, is benefiting people in your practice and benefiting your community, and it's saving dollars. So there's a lot of other things related to that. What are the things that are causing us problems? Alcohol, huge problem in the state. We have one of the highest binge drinking rates in the country. It's costing us $5.2 billion a year in this state, and yet we really haven't focused much on alcohol. Good place for community prevention services. Sugar-sweetened beverages, causing lots of problems with obesity, leading to diabetes and problems that are really causing major problems in our healthcare system. Those are things that we can address with a community prevention approach that you guys can play a huge role in making it happen.
Okay, Manny, this one's for you. How are the exchanges engaging the consumer in the exchange? I'm not sure whether you answered this or not, but I'll read the rest of it. How are the exchanges engaging the consumer in the exchange? How will the consumer be responsible for the costs, knowing what the costs are?
Oh, okay.
And have responsibility for the amount of health care the consumer actually consumes?
All right. So let's start with the engagement, outreach, education of the consumer. One of the work plans we have to build is, frankly, building out an outreach, education, and marketing plan for consumers that are going to range in a level of understanding around insurance generally, what's a deductible, what's a copay, in a level of understanding about their assessment of care and cost. So some of the things we're trying to do, and at the risk of relying entirely too much on technology, we are going to include in some of the information we provide consumers, and knock on wood, we can pull this off, information around total cost of care. So when they see a plan, they won't see just the premium, though they'll get that information. We'll give them a rough assessment based on some demographic information they provide us. We can give them a rough estimate of what purchasing this plan will mean for them on an annual basis. So, for example, if you have kids of a certain age who engage in sports, you may assume that maybe you go to the emergency room a few times a year. So that might be the kind of thing you build into a total cost calculator. Now that's the aspirational goal. It's our job to figure out a way to make that actually work. Having said that, part of our engagement is not going to be technology based. It's going to be based on, frankly, folks like you. We're counting on folks that consumers trust and get information from to be ways for us to share information about what we're trying to accomplish. So part of our outreach, marketing, and education technical work group includes providers, hospitals, community organizations, chambers of commerces. There are places where people go to for information. We are thinking through, and this was a suggestion at one of the meetings we just had in Portland that talked about exchange operational issues. What if you just asked the first 100 enrollees, no matter what their life's story or situation, and offered to help them explain their experience with exchange to their neighbors? There's something powerful about that dialogue. So those are the kind of things we're trying to creatively think about as we engage folks in trying to, what's the phrase someone used with me, trying to get excited about a grudge buy. I'm learning all these wonderful marketing phrases. This is not purchasing on Amazon, right? It's not buying books or records or cool things. It is buying something. So we need to explain to them, how are we solving a need for theirs? We've done some market research. We're going to do we're working on the final research. We look towards the end of the month, beginning of August, for that market research to be shared with the public. But here are some things that seem to resonate with consumers. Are you helping them with security? Are you helping them take care of their family? Are you helping them solve a problem around their financial condition? How we connect with those things. Now, we happen to think we're going to do all of those things, but how do we do that in a credible way that actually helps people understand how to interact with us? That's going to be some of the work we're going to be doing over the next few months.
Well, here's a couple more. Will small employers, 50 or less, or 50 or fewer, have to purchase health insurance from exchanges in 2014 or beyond?
They do not. They do have to come to us if they wish to apply for a small employer tax credit, which only lasts for 2 years. I will tell you that's probably the toughest nut for us to crack. Small employers have choices out there. They have options. There are private exchanges that are out there up and running today. That's a place where there are going to be opportunities and options. So if we can't make the case to small employers, the brokers that serve them, the insurers that service that market, and their employees that there's a value to come to us, then we're not going to succeed. So we spend a fair amount of time thinking about what is that sort of, again, apologies for using the buzzword, the value proposition we bring to all of those folks. And I think what we're hearing from them, it relates to choice. In an exchange, we can provide more choices to a small employer than they currently get. The same kind of choices that large employers are used to. Reduce complexity. Small employers kind of want to run their business. They don't want to spend a lot of time worrying about their benefit design package. And hopefully reduce cost. If we can create an environment by which we can provide access to product in a way that they can shop and compare, and by the way, do it in a tax-advantaged way, and we're thinking about all of those things, then we might have a reason to exist. And hopefully that's kind of the value proposition we make. It's not, by the way, an irrational idea. The very first time an exchange was proposed in the state of Minnesota was by my former governor, Governor Plenty, when he proposed a small business exchange. So I think there's definitely a need to provide this kind of construct for employers. Now, whether or not we're capable of meeting that need, well, that's why I stay up at night. So.
I'm just going to keep you up. How will the exchange guarantee the minimum package is adequate for acute care, chronic care, prevention, various of these?
Good question. So what's in the essential health benefit package? For the first year, it's going to be what's in our largest small group plan. And while that's not been officially confirmed, I think you could assume it's a plan sold by a carrier that also seems like an ACO. And I'll just leave it at that. That product will then have to be reviewed to see are there any components missing in the package. Having said that, that's for year one. The opportunity is for each state to articulate a set of standards that apply to those products. So that's where the fact that we're working on this is not the end of a dialogue and continued input. It's actually the beginning, or the invitation, the request for continued input and dialogue. I like to say we build the machine to be agnostic. We will support whatever policy decisions Minnesota wants us to implement. That means Minnesotans have to actually tell us what policy decisions they want us to implement. So that's where we're reaching out and looking for that feedback, that guidance, that input. This will be the exchange that serves Minnesotans if Minnesotans are engaged. And I'm glad to say that, we've been very pleased with the amount of input, but certainly more is welcome.
Another one, do you have any payers committed to participate in the exchange?
We have a lot of kicking the tires going on right now. In part because, as Commissioner Jesson said, there's still a bunch of guidance that have to come from our friends at the feds. And until that guidance comes along, their willingness, well, let me take it back. They've all expressed a desire to participate. At what level, with what plans, how much they want to partner with us, we'll see, right? And that's the other part of my job, is I have to go to negotiate contracts with all of these guys. So I'm looking forward to a fun winter.
Okay. I will switch over to accountable care organizations, I think. Accountable care organizations sound a lot like HMOs. I think you made a reference to that earlier. Someone did. How will reimbursement work? How will providers have to split revenues? Will there be gatekeepers? How will you evaluate results? Will we have population-based cost centers? And I suppose you could ask some more questions about that.
Do you want to start?
Whichever.
Yeah, why don't you start, because you get some payment issues with that.
I think accountable care organizations is, the concept was, set out in the Affordable Care Act to start with Medicare. Thinking that, large payer, let's try and move towards this. Let's try and move to, instead of, paying for, fee-for-service basis, say, okay, to start with what would it, to task people with taking care of a population. Well, but what does that mean? I mean, I think it's, you start out with kind of shared savings arrangements, and hopefully then you go from shared savings arrangements to also taking some downside risks. How much risk are providers willing to take? I mean, I think it's, I think there are going to be a lot of individual decisions, individual discussions between providers and payors about this. I don't think there's a cookie cutter approach to ACOs. I mean, but let me just go back to something we were talking about earlier, and that's that we were started down really this path in Minnesota with payment reform before the Affordable Care Act was passed. I remember, moderating a panel kind of like this one with Medica and Fairview talking about their new payment arrangements. So the idea that of what's driving ACOs, that we're looking to try and say, we'll share savings with you if you meet our quality targets. That's something we were already starting to do. But I do think that different ones will look different. We're in the Medicaid program, as many of you all know, we are in very active discussions with 9 different provider groups across the state of Minnesota. And I think at this time next year, we'll probably have 150,000, something close to that, of Medicaid enrollees that are in, that are getting their care through some sort of ACO. So I think we have to make sure it works for us here in Minnesota.
And certainly, I mean, ACO is a concept that is not fully fleshed out yet. And obviously, if ACO is going to be something other than, a redux of an HMO, we really do have to take that population-based approach. And that requires a fairly large population in order to manage population health. So we need to figure out ways to really look at a large group of folks, probably 100,000 people or more, in some kind of an ACO, so you can actually change the curve of the cost and actually get some health outcomes. And that's where you can shift resources to do the prevention things that really are required. We're not quite there yet. We have some models that are starting to look at that, and it's certainly going to be an evolution over the next several years.
For the next biennium, how much money will the state save, general fund and healthcare access fund, if the state agrees to expand Medicaid to those earning up to 133% of the federal poverty level with federal payment of the costs?
We are looking at our numbers now. I mean, the idea that it would be a state choice on the Medicaid program is something that's new. So we actually are spending quite a bit of time looking at just what that will mean in savings to the state. And then we're, it's kind of like, we can come up with basic numbers based upon state savings. Some of those were already built into our state forecast. So we kind of assumed that, I think the people who do the forecasting assumed that Minnesota would be doing the Medicaid expansion. So some of those dollar savings were built in. Now we have to say, well, maybe we can't make that assumption. So I think that is a work in progress, but there certainly, at the end of the day, Minnesota saves money if it does there's no question about that, by doing the Medicaid expansion. Because I said, these are people that we are basically covering with a lot of state dollars today.
There's a lot of very good what-if questions. Here's one on Medicaid. If 26 states opt out on the expansion, I take it, what might be the impact on Minnesota's providers?
Well, one, I don't think 26 states are going to opt out. I've been following this pretty carefully, and you have a lot of governors, including a lot of Republican governors, that are saying, look, we need to take a look at this, we need to be careful. You have a few that are saying we're not going to do it, Governor Perry, I think, in Texas. But even when you actually listen to, for example, Governor Walker from Wisconsin, what he's saying is, I'm going to wait till after the November election to decide. He's not saying no. It's a whole lot of money, for federal money, and good care for people, for states to pass up. So I just don't think there's any possibility 26 states are going to say no. If you think about it, states had the option to opt into Medicaid to begin with, and it took them a while, but they all opted in.
Okay. As long as you raise the November 6th question, which seems to be paralyzing a lot of people these days, what will be the impact in Minnesota if the ACA is repealed?
But we had this conversation, prior to June 26th, and as we stated, Minnesota's been working on health reform for a long time, and as you pointed out at the beginning, we can't stop. We can't go back. We can't just say we're going to do things like we've been doing for the last 30 years. We need to move forward. We set things in motion several years ago, looking at population health, looking at improving access, looking at paying for quality and value. Looking at systems changes, looking at providers and efficiencies, looking at various levels of coverage. We're going to continue to do that, but I don't think that ACA is going to be repealed. I think people are going to recognize that this is a good step forward, needs to be tweaked, it's going to be modified over the years, but it's a good start, and it has some really sound basic principles that it's built on.
Can I add one thing?
Sure.
I told you all I had to speak on the ACA at less than an hour after it came down. So I have version 2 ending of my speech, which is titled, version 2, entire ACA struck down. But
so you can pull that up again.
So I can pull it up again, but I'm with Commissioner Ehlinger. I don't think that's going to happen. I mean, you're more the politician, but I don't see it.
Okay. I'll tell you on November 7th, right? Okay, and now we're getting to the docs. What are the options for physicians who want to remain in small private practices? And we all focus that one on rural Minnesota in particular. Anybody want to?
Well, I think we're going to have.
Doctor, please.
As I look around the state, I see some real disparities in health outcomes, urban and rural, and I think we need to really look at the kind of system of care that we have, particularly in rural communities. And I think we're going to be looking at options. I really want physicians to be able to practice at the top of their game, doing the things that really only physicians can do. And I think we need, if we're looking at population-based approaches, if we're looking at integration of care with public health and social services, I think we're going to have teams that are going to be necessary to really work and provide care. And I think there's going to be a physician, by him or herself or in a small group that certainly would be part of those teams, could be part of a broader ACO throughout the state. So I think there are some options. I think it is on a macro level. I think we're going to have to look at large groups if we're going to change population health outcomes, but I think how we aggregate that is going to be more of a statistical one than necessarily an individual practice one.
Here's the related question. Are there any plans as to how opportunities for telemedicine might offer would be part of some or all of this?
That's something that actually the Governor's Health Reform Task Force is talking about in their workforce work group, and I see Dr. Teresa Zink here, who is head of that work group and a member of the Governor's Task Force. And Dr. Zink could probably fill you in more detail, but she came up with a number of excellent recommendations, including ones around telemedicine to address some of the needs, the workforce needs in rural Minnesota. So that's a hot topic.
Senator, if I can chime in. To follow up on the telemedicine question, one of the things that the Department of Commerce has been working on is the Governor's Broadband Advisory Task Force. One of the principles guiding that task force's work is to ensure that access to rural communities in part serves the needs to provide or facilitate provision of care via telemedicine. It's hard to do that on a dial-up, so,
Yeah, so, and it's certainly the e-health initiative that we're doing really focuses on laying the groundwork for a lot of the telemedicine and e-health.
Yeah. Here's a couple of related questions I'd like to ask, and which includes an observation of my own, I suppose. But decreasing healthcare costs through public health and prevention require that individuals change their behaviors and their lifestyle. What in the ACA or state policy will influence people to make those choices? And here's the related question. Patients, consumers, whatever the name is we're calling ourselves these days, have to work with their health team to achieve optimal results. How do we incent them to be active, not smoke, lose weight, take medicines, exercise, all the rest of that sort of thing? And my 32-year-old doctor asked me that same question because they made him the quality improvement person in his little clinic, and so they got all these older doctors, that have to report to him on the community measurement project. I think it was asthma we were talking about, and they say, well, people aren't doing it. And I said, the only thing that occurred to me to say was, how do you think dentistry has convinced us, every one of us, that every 6 months we got to go to the office, and we got to go through this examination, we got to floss in between, and we got to do this. How do they do that? Let's figure it out. Anyway, what are your answers to this?
Well, certainly, individual choice is really important, but that choice is made in the context of what choices are available. So one of the things that we need to do is change the environment. It's hard to eat good food if you're in a food desert. It's hard to get exercise if you're in an unsafe neighborhood. There are a whole variety of things that we need to change the community environment so people really encourage people to smoke or to do the right thing. Certainly changing the environment. I was thinking about smoking. The fact that we changed the environment so it's harder for people to smoke now, and it's easier for them to make the decision not to smoke. And I think that also the clinical preventive services that are really encouraged with ACA, it starts those conversations, starts the screening, starts the conversation in the clinic that then need to be supported in the broader community. So it is a collaboration between the clinical side and the public health side in changing the environment so individuals, it's easier for them to make the right choice. We're certainly working with schools on food in the cafeteria, in the food service, making it easier to walk or bike to school. We certainly worksite wellness, making it easier for folks to do wellness programs in the worksite. Changing those community norms will be part of helping individuals change their behavior.
We do have to change the incentives for people too. And one of the things that the ACA does, a couple of things in concrete ways, in addition to what Dr. Ehlinger said, is one, they enable employers to actually vary premiums more if they have a workplace wellness plan, and they enable them to give incentives to people to try and, lose the weight they need to, lower their blood pressure, meet some of those biometric conditions. And then if they have an adequate, workplace wellness plan, they can vary those premiums by, up to 30%. It used to be only 20%. Now, there's some real issues about doing this in a way that's fair to people with disabilities, but I mean, that's a concrete change. And actually, one of the things we're doing in our Medicaid program, working with the Department of Health, is we actually got money, $10 million from the ACA to try an incentive-based program in the Medicaid program. We have a lot of people with pre-diabetes, so we are going to, we have using the diabetes prevention program, we're going to be offering that to a lot of people, Medicaid enrollees in the metro area, and we're going to divide them into 3 groups. One of them, they get access to this. It's an additional benefit. Another, they get access in incentives. Incentives for showing up, incentives for losing weight. And another, they get individual incentives plus group incentives. So we're trying to test it out. The ACA, I think, is giving us some tools, some dollars, not only in the employer arena, but also in the public sector arena to say, let's figure out what incentives work, because we really do need people to have the opportunity to take charge of their health, their own health.
And let me add that around aligning incentives with people's behavior, I would posit that for some people, their financial well-being is some form of incentive. So think of an exchange, having access, or not access, but being a place where people can connect in a transparent and direct way the relationship between their behavior and the premium they're paying. And by that, we're thinking about one of the challenges of providing wellness and sort of continuity care to individual consumers right now is if you're a carrier, that's a real pain in the tuchus to go sell on a one-off basis. But what is in exchange fundamentally but a place to aggregate all of those consumers? We've now made, hopefully, the ability for a carrier to sell wellness programs, to sell continuity care, easier for individuals. Now have we provided individuals a way to access those programs in a way they couldn't have done so in the previous marketplace. Again, that's an aspirational goal. Don't hold me to it. That might be Exchange 2.0. But that's a place where the mechanism of this electronic marketplace can align financial incentives with wellness.
So let's thank our public servants for their work.